Okay, there it is. We both just hit the button. And here we are. This is Jay Brown Yoga Talks podcast. My name is Jay Brown, and if you're new, let me welcome you. Everyone else, what's up? I don't even know why I asked that. Fucking pandemic, that's what's up. I'm sorry to cuss like that right off the bat, but I guess I'm just having one of those days with the whole thing. One of those off-kilter days. Sometimes I feel very grounded, like I'm really navigating this surreal moment, and I feel like I'm okay and everything's cool, and I have a sense that even though there's all this uncertainty, I've got this clear sense of myself that's going to get me through. And I still feel that way, but sometimes it eludes me, and I feel myself swaying with the waves or getting blown with the winds. And I don't know, today felt a little bit like that. I think I was reading a little bit too much news, to be honest with you. And I must admit, I feel maybe a little bit apprehensive about today's episode. Not really, but a little bit, because I'm talking about it. I'm talking about the pandemic and whether or not we should wear masks and my feelings about the social distancing and a bunch of things that I haven't spoken so directly about in an episode. Like I keep mentioning little things here or there in these intros, right? You know, I'm talking about it. It's not like I'm not talking about some, but you know, I'm kind of in and out in these intros. It's not like I've spent a whole hour and a half plus talking about these issues. And today we do. And if that wasn't enough, not only do we talk about the pandemic and all this stuff around that, we also talk about Black Lives Matter. It's like, we just got it all in there. And that's because today's guest is Dylan Galos. And Dylan was on the show before. We talk about that at the beginning. And when I last spoke to him, he was finishing a degree in epidemiology. And also, he identifies as a queer black man. So we couldn't not also talk about what was happening with Black Lives Matter. Now, there's a few things I feel like I need to say before you listen to this conversation. And I don't usually do that these days. I don't offer a lot of caveats in intros anymore. I used to do it back in the day when I was just feeling really insecure about them. But now I try not to put any disclaimers or caveats because I want you to hear it with fresh ears. However, there were some circumstances around this conversation that need to be shared. And Dylan and I had an email exchange after we recorded it, and there's a few things that he asked me if I would say here in this intro and emphasize, and I am happy to do that. The first thing is that this episode was recorded just like a week or two ago on July 1st, and things have been changing quickly, so some things may have already even changed some since we were talking. And that goes to one of the first points he wanted to make, because I was in a real state. I should also mention that, and I don't mean this as like an excuse or anything, but it's a fact. If you were listening recently, you know I had this like tooth infection and I was on antibiotics. And the day I recorded with Dylan, I was on antibiotics, and earlier in the day I felt fine, but we recorded in the evening, which I don't normally do. We recorded at like 8 p.m. at night. And by the time it was that late in the evening, I was feeling a little bit loopy. So I was not feeling my most sharp, and that was not ideal given the depth and difficulty of the topics we were talking about. And I feel like I put Dylan in a very unfair position in several moments in the conversation where I think that, like many people, I have frustrations over everything that's happening. And in this slightly altered state I was in, it was almost like I was taking it out on him in some regard and in a few moments. And he didn't deserve that. You'll hear Dylan is like the sweetest person you'll ever meet. And he was so kind to me to be on the show. And in any case, let me mention the things that he asked me to emphasize. The first thing is that, as I was saying, things may have already changed. I really am questioning some things in this conversation about science, and he wanted to emphasize that, the reason why there's these contradictions in the health information is because science is self-correcting. So as more evidence comes in, you get different conclusions. And as new information happens, then your opinions evolve with that. And I think that's a perfectly reasonable premise. And I think that the point is, even when there's reasonable questions to be asked, it doesn't mean all science is bullshit. And I don't think I suggest that in this conversation. And we just want to be clear that even though there's questioning in this conversation about different aspects of science, it doesn't mean that we don't believe in science. Now, along with that is that as situations change, there's going to be new recommendations. So I express a lot of confusion and, again, frustration around the policies that have been implemented to deal with the pandemic, because a lot of them don't always make sense to me, as I'm sure they don't always make sense to a lot of people. And I think Dylan just wanted to make it clear that we should understand that there's going to be new recommendations and things are going to change as situations change, because this is evolving science. And one of those recommendations that we do discuss is wearing masks. And we talk about the effectiveness of wearing a mask. And just in that conversation, there may have been some ambiguities. I was a little all over the place. And so I just want to be clear that I'm not suggesting you should not wear a mask or that they're of no use or not helpful. So for whatever that's worth. And lastly, Dylan does mention Dr. Michael Osterholm as well as several other resources. And I have provided links to all of the resources that he mentions in the description if you want to click through. He references Dr. Osterholm because that's one of his go-to people right now. And, he's someone who's really been putting out the alarms to people because from his perspective, COVID is different in the sense that it's easily transmitted. People are pre-symptomatic for multiple days, and there's a substantial number of people who are asymptomatic, which we talk about. And so all of that, he says, is what makes it so easy to spread and so hard to contain. And that's why they are raising so many alarms, and that's why this has happened. From an epidemiological standpoint, right now, only something like 5% of the population has been infected. And to get to a place where we have herd immunity, which we talk also about, you need to have like 50 to 70%. So from like a pure epidemiological standpoint, this is like a serious long haul situation. And I think he just wants to make sure that we have our heads in the best place that we possibly can to deal with all of this. So there you go. Having said all of that, it's a really incredible conversation. You'll hear it, I think, really speaks to what a lot of us are grappling with. And I'm just so very grateful to Dylan for the kindness and consideration he showed me. And I'm excited that you're going to get to hear this today. Before we do, let me mention that this episode is brought to you in support from podcast premium subscribers Samantha Hardees and Simon Goss Jr. We're so grateful to Samantha and Simon for being podcast premium subscribers. We've been shouting them out these days because they are supporting and sustaining this show. Really, it's the best way to do that. You also get full access to the archives, but the small gesture of becoming a podcast premium subscriber is really what's enabling us to keep this coming to you every week. And if you've been listening and you would like to make that gesture, you can become a podcast premium subscriber too. You can find out about that along with all of my other stuff, my live stream classes and my teacher's class and all the other jazz. All my stuff can be found at jbrownyoga.com. Okay, I think that's good. Dylan and I talked for a while, so we're just going to leave it there. I will touch base with you for a few moments on the other side so I can tell you about what's happening next week, which is also very interesting and exciting. But for now, let's go ahead and get to it. Let's listen to this conversation that I had with Dylan Galos. Hello, Dylan.
Hi, Jay.
Hi.
It's good to hear you.
It is good to hear you. It's been a minute.
Yeah, no kidding. When was the last time we talked? 2017, I want to say, 2016?
Yes, I was just looking before I got on with you. It was April 2017 is when it posted, so we probably recorded, a few weeks before it posted. So sometime just a little over 3 years ago, that's right.
Wow.
It's crazy how time has gone.
Yeah, I would say time flies because those 3 years have felt pretty quick. But then on the other hand, 2020 has certainly felt like a decade, and we're only halfway through it.
Oh my gosh, you're telling me. I mean, it's been such a crazy moment. And it's funny because in this crazy moment is really, it did lead me to reach back out to you because I've been having all these conversations with folks, about everything that's going on. And, in these conversations, a lot of times, and I'm including myself, perfectly reasonable people have questions about some of the official narratives that get put out, And the answer is always, we need to listen to the epidemiologists and the virologists. And so I thought, well, do I know any epidemiologists? And immediately in my brain popped you because I wrote epidemiologist in the title for the podcast that we recorded 3 years ago. And I was like, Dylan, you were like an epidemiologist to be at that time, if I recall. You were still finishing, is that right?
Yeah, I was just a couple of months away from defending my dissertation, so just almost done with my PhD.
Right. And I think I have a memory at least from like social media posts since then that you did finish the degree and graduate and are like now an official epidemiologist. Is that right?
Yeah. I mean, my job title is officially like program evaluator, but yes, I finished my PhD in epidemiology in May of 2017. I actually defended on May Day, literally May 1st. So it was a May Day kind of situation.
Got you. And I know also I have a memory that you did move as well. Is that right?
Yeah, I've actually ended up moving twice. I moved to Columbus, Ohio for a job last year, and then I ended up moving back here to Minnesota. I live in St. Paul, Minnesota for another job. And so I've been, I'm happy to talk about this because I moved in the middle of the pandemic. Everything kind of shut down around mid-March. I started my current job mid-April, and I left Ohio on April 1st. So I got to see a lot of what the lockdown was like in different states, and that was quite the experience, to put it delicately. But I made it safely. I'm lucky to be employed. I'm actually really enjoying the work that I'm doing, and I do a little bit of COVID work in my current role, and I'm happy to talk about that too. But yep, that is all correct.
Wow. So I guess maybe just to be really clear, and maybe it's kind of a dumb question and a dumb place to start, and maybe you even said this last time you came, but perhaps you wouldn't mind saying it again in your own words. What is the job of an epidemiologist?
That is not a dumb question at all. So epidemiology is the study of the determinants and distributions of health-related states and events. So that can include diseases, that can include pathogens like viruses, bacteria, parasites. It can also include injuries. It can include violence. It can include a lot of different things. You can include mortality from cardiovascular disease, like a myocardial infarction or what we call a heart attack. So a lot of different things. And the job of an epidemiologist, depending on where you are in the spectrum, some people in the state or the federal government really try to understand what the distribution of different diseases are. Really trying to understand what the diseases of risk factor or what the prevalence of risk factors are. Prevalence being how common a certain thing is at a certain point in time. There are people who really focus on causal inference, who are really trying to understand what causes different health-related states and events. There are people who really try to focus on testing interventions, seeing what works. So there are a lot of different things, but by and large, us EPIs work with numbers. And of course, I really wouldn't want to ignore, especially as we're talking about an infectious disease. There are what some will call shoe leather epidemiologists who actually are out there on the field identifying how common diseases are, tracking an outbreak, going through the very difficult and very complicated work of identifying how an infection has spread within a community. So up until recently, a lot of my friends who did this work in developing countries. Like I have several friends who've worked in Africa doing many different types of work there. And there are people who do it here in the United States as well, because there are certainly infectious diseases in the United States too, before coronavirus and including COVID-19. And so it's a really huge field with a lot of different titles.
Right. And if I recall, I mean, you just said that it is a lot about numbers. I remember you talking last time you hear about data sets, right? And you were putting together a data set. And if I recall, you were working on abuse, right? Like,
yeah.
Remind us what you were working on when you were doing your PhD or when you were finishing.
Yeah, certainly. And if it's all right, I'd actually like to just kind of start with my whole background,
Sure.
Just for the sake of transparency with the listeners, so they can get a sense of what I do know and what I don't know, because I think that's very important. We don't have as much transparency in the communications about coronavirus as we would like.
Okay, I think that's smart. Please go ahead.
So my undergraduate studies were in biology. I was born and raised in New Mexico, and so I studied there. I focused a lot on public health in the last couple of years. I was one of those undergrads who didn't really know where they wanted to go. I really thought science was fascinating. I was really interested in pursuing a career in science. I didn't really like working in labs. It wasn't for me. So I worked in labs working with animal models. I worked in labs working with chemistry experiments, with lots of different types of really cool work, including neuroscience and stuff that really came in handy as I became a yoga teacher, which is a whole other conversation. Mm-hmm. I did my master's degree in environmental health sciences, which is essentially the intersection of where the environment meets human health. So that can range from things like pollution and how airborne particulate matter can affect our lungs and can even lead to different diseases like cancers, heart disease, and many other health outcomes like asthma and respiratory diseases. It also can include things like studying climate change and how emerging infectious diseases can result as a consequence of deforestation. My specific area when I was doing the work was really around risk perception and around pollution within the inner city in Columbus, Ohio. That was what I did my master's thesis on. And then I went to do my PhD in epidemiology, and I finished that 3 years ago. And so I focused specifically on social and behavioral epidemiology. So I'm much more interested in the questions about the social mechanisms that lead to exposures, as well as the behaviors people have inside those social structures that lead to our exposures. And I make that distinction because there is also a set of folks who do research on clinical and biological epidemiology, where they're really focused on very minute, very specific mechanisms within the human body, and they really go into depth with those kinds of causal mechanisms. And though I'm familiar with science, I took a lot of that background. I've taken courses in clinical trials and a lot of the data analysis. My area and my wheelhouse is not as an infectious disease epidemiologist. So I just want to be clear to the listeners that is not my specialty.
Right. So you said clinical, biological, and then what is what you do more behavioral? Is that what you said?
Yep, more social and behavioral. And so so my dissertation, to your earlier question, was on the topic of intergenerational child maltreatment. And what that means in plain English is that saying that apples don't fall far from the trees. So when you hear about someone who has experienced physical abuse or sexual abuse or neglect, the idea is that then they are more likely to perpetuate that abuse onto future generations within their family. And the theory has been widely held within the field of social work, and it actually emerged, I think, in the mid 20th century. There was a physician who observed certain characteristics of parents whose kids were in the hospital for abuse. I think his name was Kemp. And this theory then became something that goes on, and that became popular in the field. And there is definitely some truth to it, in that larger studies have found that people who experience abuse are more likely than people who have not to perpetuate abuse or to become offenders later in life. But the vast majority of people who have experienced abuse, who have survived maltreatment, do not go on to perpetrate it. And so my dissertation was really examining 15 years of statewide records to see how many people of a pool of people in 2000 who were listed as victims in child maltreatment reports then appeared again in their adulthood as offenders, which was a limited generation. But the idea of seeing how often did people have contact with the state multiple times in life. There are a whole bunch of issues with how you define it that are kind of outside this conversation, but it was really around this idea of tracking something across multiple generations and really understanding whether this large data that we do have is even able to answer some of these questions. It was a really fascinating project, and since then I've kind of gone on to do very different things, but that is a bit about my background. Right now I do a lot of work in physical activity. I do a lot of work around active transportation, so biking, walking, getting around by scooters, as well as seeing how that impacts our health, and I'm really excited about that work. It's kind of one of my big passions. And a lot of what I do for COVID is I do a lot of work understanding the well-being of the staff at our health department who are working in the COVID response. And so I'm lucky to work with the team of people who are really trying to help the helpers.
Well, thank you for that. I guess I'm curious about, like, for instance, when you talked about what you were working on, it's very clear where the data, like how your data gets collected, is essentially like court documents, right? Or documents that show whether someone was registered in the system and had all that stuff when they were kids, and then you could check court documents later to cross-reference that. That's right? Or is it coming from surveys, or is it, in your instance, it was just coming from court documents? Is that right?
Kinda, yeah. It was administrative records. So this was a data linkage project. Actually, that was a larger thing that I was just lucky to be able to use some of their data for. And it's a whole onerous process of getting access to this kind of data. For the listeners, to be clear, people take privacy very, very seriously. So the idea of getting multiple years of records from one state agency and connecting to another, it was in a super secure data lab. So I was using 15 years of records of abuse and social work from the Department of Human Services, from their Child Protective Services unit. And then I was linking that to data from the Department of Education to understand how this ties to education, as well as having some better demographic data. And so, trying to link with some specific identifiers. And then I was given an anonymous data set that was de-identified, and I had to go to a specific data lab during certain hours where I had no access to having the data outside of the lab. I was able to get some of the results and write my own stuff outside of it, but any work with data was in a very secured facility. So I also just want to make sure that message is clear.
I mean, I guess that's kind of why I'm asking about that. It just seems to me that how this data that epidemiologists use gets collected is pretty important and invaluable, like you said, or privileged, like it's people's privacy is there as well. So I guess I'm just curious about how these data sets get created,
Yeah, I'm happy to go into that a little bit. So it's interesting. So this was a process where it's basically we don't have say a unique identifier or a number that you can use to connect people across all different things, right? Some Scandinavian countries will have a state ID where you can actually connect between different systems. In the US, that's usually not the case. We take privacy in a very different direction. And so we don't want to have some sort of identifying information that could connect people in a different way. So what it required to have just these administrative records connected was a lot of negotiations, something being put into state statute, and data sharing agreements between not only this institution, but then also the agencies that had their data, review processes of everything. So everything that I published had to get reviewed by the state for 30 days before I could go public with anything. So when I was finishing my dissertation, I actually had to have everything ready a month before I even needed to be ready to present it. So if I was presenting something on, say, April 1st, then that meant that by the end of February, I would have to have whatever I was presenting ready. And it put me on top of my game, but that is the kind of scrutiny that this kind of work goes under. And so using other ways of connecting people, things like matching names and birth dates. And that's something that someone is usually given very special permission to do. Then someone who is analyzing the data, like myself, is given a data set that has a scrambled ID or a new ID that's made that has no connection to someone's actual records. And then that was what I was using. So that was something that was much more at the aggregate level, where I was able to report on something at a larger level. So say in terms of, mine was statewide, but you could imagine doing something within a county or within a city, and then use that. And so these administrative records, where these are things from the agencies. So the examples I used were the documents from Child Protective Services. There are also a lot of folks who do research with records from vital statistics, so like birth, death records. There are people who do research using electronic health records. I've done a fair amount of that work as well. So records from hospital systems, and that's a whole other wheelhouse too. And so that's a whole field of research.
So the permissions that you need in order to see that data comes from government officials?
At the end of the day, I would say yes. I mean, I didn't have to speak to a government official to make it happen, but the department that housed the data set that I worked with, they had to negotiate all of these legal agreements before they could let anyone have access to that data. And then anything that I did had to go through several review processes just to make sure that people's privacy was taken seriously, that nobody was identified, that the findings were reviewed so that people could really understand whether the data was used appropriately. So if someone was going to use the data in a way to, say, scrutinize specific populations or trying to present something in a more controversial way and wasn't necessarily being scientific, then that's another set of reviews that happens. And I didn't have any feedback like that. I didn't get any feedback in my review process. But does that answer your question?
I think so. Yeah. I mean, I guess I'm just, there's all this data that we get these days, like more so than I ever remember. And I always feel like, it'll like we'd have new cases. That's the big one, right? How many new cases? But then it doesn't always say like how many new cases are asymptomatic or not, or even the way like I heard a bunch of stuff about all the different kinds of testing that's being used to try to collect this data. And then you've got data from other countries where they don't actually use the same exact protocols for their testing that we use for our testing over here.
Mm-hmm.
And it just sort of feels to me like I'm just sort of curious from an epidemiological standpoint, the data can be changed depending on like the protocol you use to collect the data.
Absolutely. And I think this is a really important topic, so I'd love to dive a little deeper here. So when you say that it could be changed depending on how you define it, what do you mean? Because there are a lot of different ways you could go with that.
Well, and I guess I'm just drawing upon things that I've been reading and hearing, and some of it, again, I don't promote this. I don't know that this is true at all, but I heard someone talking about the testing process and how there's a process of what they call enhancing it, and there's like cycles of how many times you do it. And some places will do 3 cycles, some places will do 6 cycles, or like depending on how many times you enhance this, you can end up getting more or less positives.
Gotcha. Yes, that is absolutely true. So depending on your lab testing, you're going to get some different results. And so I think when you're talking about those kinds of tests, it sounds like you're talking about the actual viral tests where we're looking to see whether someone has an active COVID infection at the moment.
Yes, that's what I was talking about.
Okay, because because there are the 2 different types of tests that we have available right now in the broader categories, where there are the tests of measuring whether someone has the virus present inside of their body, which is the one where we usually go up the nose. And then there are also the antibody tests, which is testing whether someone has had the infection before. And there are issues with both of those, but and there are different issues with both of those, but absolutely. So depending on, and I can't speak to how to these differences in protocols as to whether or not 3 to 6 times would lead to a meaningful difference in conclusions. It certainly seems plausible that you could find, say, if you enhanced it, or if you redid this 6 times, you might find something different. But I think it's also important to highlight another issue with some of the viral tests, which is that my understanding is that is not always the best understanding or the best diagnosis of someone having an active COVID infection, because sometimes there are still viral particles that happen that stay in someone's body for a long time, sometimes weeks after they have already had an active infection, which is why you see some of the people who end up having these fluke repeat tests where they test positive several times and can't get out of quarantine or can't see their family or something like that. One of the podcasts that I listen to for information, and I'm happy to share some of this toward the end, really talked about this being an issue that has been raised, and so it's not necessarily treated as the gold standard of whether someone has an active infection in that sense.
So that's interesting to me. So is there, of course there is. Why am I even asking, like epidemiological, like little circles of epis who like talk about stuff and are like talking about what's happening, like on that podcast, for instance? Is that what you're talking about?
Well, so this podcast is Michael Osterholm's podcast. He is an epidemiologist in Minnesota. He is a pioneer in the field of emerging infectious diseases. And so he's a medical detective who's really done a lot of groundbreaking work in terms of understanding how diseases spread, how epidemics will happen, and really diagnosing and predicting what they'll look like. So he's someone who a lot of listeners may have heard of, appearing on various national news circuits. I think he actually was on Joe Rogan's podcast too, and that's when some people started taking the taking the epidemic more seriously. But he has a weekly podcast where he really reflects on a specific issue, talks about the scientific evidence, and goes into more depth. And it's really his scientific opinion, which I take quite seriously. And so it's one of the sources that I've turned to pretty regularly to make sure that I stay informed about his perspective. And so this is one of the issues that people are having within the field, is really understanding whether a repeat positive test in this case means that someone still has an active COVID-19 infection, which is fascinating to think about and just mind-blowing to think about too, because I remember being really alarmed hearing these stories about someone who tested positive for a month or tested positive for 6 weeks.
So what are we to make of that, though? That idea that you're positive, even though you're asymptomatic, you don't feel anything at all, but you're still actively spreading it to other people. Is that what you're saying?
No. So this is a case where someone, say someone has been infected with COVID-19, SARS-CoV-2 is the virus's name. But say someone's been infected, let's say last week. Typically what we see is that people have onset of symptoms pretty quickly, but then usually 2 to 3 weeks, they are usually not transmitting the virus. But they might still test positive by a viral test for several weeks after, not because the virus is still actively replicating in their body and making them contagious and making them a threat, but just because there are still viral particles that are left, viral DNA that's left, or copies of the DNA. I think COVID-19 is an RNA virus, but copies of the virus, or copies of some particles of the virus, enough to test positive in the lab, but not necessarily indicating that there's an active infection. So it's sort of a false positive, if you will. It's positive in the sense that, yes, there has been this virus, and yes, they have been infected, but false in the sense of, no, they are not contagious right now. And so I can't speak to the exact frequency with which that happens, but it's happened enough that there's been some debate in the field about this.
But if that can happen to somebody like who's already officially had it and experienced symptoms, is like you're saying, conceivably that could happen with someone who's asymptomatic too, where they still have virus in them that's not active anymore, but would come as a positive.
Certainly. Although when we talk about the asymptomatic, I think it's important to distinguish whether we're talking about someone who's asymptomatic because they have already fought the virus, whether they have already kind of gotten past that stage of their infection, whether they're asymptomatic because they don't have any of the symptoms that we test for in COVID, or whether they're pre-symptomatic, where they don't have symptoms at the time they're tested because it's so early, but actually 2 to 3 days later, they do develop symptoms, and in that time, they are contagious.
Right. I guess the thing that freaks me out the most, or not that it doesn't necessarily freak me out, it's confusing the most, is someone who, I guess, has it, tests positive, but has no idea they have it because they've experienced no symptoms that they were noticing. And there's a pretty high percentage of people who that's the case. Isn't that right?
So my understanding is that the asymptomatic rate is somewhere between 20 to 50%, but with the caveat that we're only 6 months into this pandemic really getting a lot of study, and the studies that have found those numbers have, of course, been important, but they've been in very specific contexts. So, when we see that number, I wouldn't take that number and then think half the time that means that someone doesn't have symptoms. It could mean that half the people that this scientist crossed paths with and who were willing to do a swab ended up being positive but had no symptoms at the time. And so we don't know what the exact number is at this point.
No, because if you didn't have symptoms, you would never know. You'd have no reason to get tested, Yeah. All right. Well, you were saying that you were working with the frontline healthcare workers. Does that mean you're working with the doctors and the nurses at the hospitals and keeping them well? Is that what you were saying?
At the health department, it's more focused on the people who are doing things like the lab testing, people who are entering the data in the labs, people who are answering the calls, people who are really leading the response. So this is really I've learned so much in the last few months working for the health department. But this is where the health department is responding to a disaster and really being proactive in that response. And so what that means is that then people get reassigned from their regular jobs to respond to COVID-19. But because this has been unprecedented and been unexpected, it's also meant that people have been asked to work long hours, to work extra days, where typically we might have a response like this for something that lasts a few weeks, but this is something that's gone on for a lot longer than we would expect. And so the idea with this is really understanding who in the agency is working a lot of hours and needs some support. Are there areas where maybe we need more people? Are there people who may need to either rotate out of their positions, come in and out because it's such a high pressure thing? But just really making sure that the people who are really responding in this way are able to work, are able to continue the work, and that it's not having a hugely detrimental effect on them in terms of burnout.
Right. I mean, I guess that's certainly true for those folks and working to meet the crisis and do the work that they're doing. But it's kind of true for everybody as well. Like the ongoing strain of the situation is having an impact on everybody's health, I think. Certainly mental health, I would imagine.
Absolutely, for so many different reasons. We've seen suicides among physicians across the country. I read a really heartbreaking one in the New York Times where this physician, she was a rock star and she was really doing great work, and then she committed suicide, and no one saw it coming. It happens among physicians more than we'd like to think about. Burnout among physicians is a very real thing. But in the general population too, this is having a huge impact. I think when we have this situation where there's great uncertainty, there's great economic instability, we have this lack of social connection for people who are, say, very touch-oriented, myself being one of them. It's very hard to stay isolated. I live alone, so I'm grateful to have a cat. I am grateful now to have a weighted blanket, but that isolation is really hard on people's mental health. And, we have Zoom fatigue. So in the general population, we see that. Whereas I think folks who maybe have kids, folks who are living in a household with their spouse or roommates, all the stressors of that situation also get amplified. I've heard from a lot of folks. It seems to everyone is affected by this. To your point, it's absolutely true.
Yeah, I guess that's the confusing contrast is when you talk to people who are at the hospitals and dealing with the people who are coming in ICU units and what they're facing, or some of the scientists who are on the front line, like that doctor you're referencing, and the things that they're saying. And then it's easy because, where I live, we closed down pretty early. I got to give my governor here in Pennsylvania good credit. He was early to follow the protocols, and we didn't see as much. I mean, we're pretty close to New York too, but in my county, Northampton County, we really did bend the curve, as they say. We did manage to do that very effectively. So I haven't had it immediately affecting me. And just when you look at you're talking about data sets, I was doing this reading and I was looking at they have the Diamond Princess data set of that one ship that had an outbreak. And when you look at those numbers, it makes you feel this isn't as bad as they say, because, it is bad, but, the amount of people, the infection rate, and honestly, the ages of the people, the median age is something 80 years old. And so I could see why there's a lot of people who are like, well, this is something that's really affecting old people, and why are we shutting down everything when maybe we should just be, protecting the people who need to be protected?
Yeah.
I guess I know you. I don't know if I'm saying that as a question, I guess, because it's. Do you think that it's being overhyped?
Personally, I do not think it is being overhyped. I personally think that there are parts of the country right now that are not taking it nearly seriously enough. That being said, I can also understand why a lot of people might feel it's overhyped. I can understand why people might feel extremely frustrated by everything that's going on. And I certainly can understand why people were not anticipating that it would even go on as long as it is now, let alone even until May. I was pretty... I will admit, I was actually not too hopeful. I was pretty skeptical about what this might look like. And I can talk about why in a minute, but I also can understand why people wouldn't know that, and wouldn't think that. And so I can understand why someone would have that position, even though I very strongly disagree with it.
Mm-hmm. Well, why were you skeptical? I mean, I guess people were just painting too rosy of a picture. Is that what you're saying?
So I think part of it, yes, people were painting too rosy of a picture, but then also it was just the level of response that I saw. I can remember even back in January when this really started to get published in some of the more, I think this was more in the more medical journalism that people were talking about this. Sometimes in the health section, people were talking about this novel coronavirus that was happening in Wuhan. And I was really interested in it in the sense that I thought this was going to become a big thing. But I never imagined, that it was going to become something of this scale. But then in March, when things started shutting down, it really seemed... I was skeptical so I was in Columbus, Ohio, and at that point, they started phasing things down pretty quickly. And so I remember just having this feeling as we started getting the guidelines to wash our hands, as we started getting guidelines to buy more hand sanitizer, I remember thinking this was very strange. And then in those last few days, before everything shut down, I remember just sort of wondering if this was going to be the last day. So, for example, I went to the gym and I made sure to thank everyone. I worked out at a small family-owned gym in Columbus, and I thanked the owners and everything because I thought, is this going to be the last workout? And at the same time, I was probably sanitizing mats down and sanitizing every bench down so much that I was wondering, should I even be here? And then later that day, the governor closed everything and had a lockdown for a couple weeks. And so there were people who thought we were just going to be locked down for a couple weeks, for a month, something like that. And I certainly hoped that. I was wondering what this would look like. And then as data started coming out and people started talking more about what this looked like and why people were taking it so seriously, as people talked about the level of infectiousness with the coronavirus and how quickly it can spread and what this looks like and the capacity issues for the healthcare system, that was another thing. And then there was a really influential set of models that came out sometime in April, I forget exactly when, that really went into detail about the potential situations that could happen. And they're models, so they're not necessarily right, but there were 3 potential ones, and none of them had the coronavirus looking like it was going to be a short-term thing. It was really looking like it would be optimistic to be the end of this year.
I mean, if I recall, some of those models were very scary, like millions of people dying.
Yeah. There was that too, and
And that it hasn't happened like the models have said. I'm not saying it's not bad and that we still don't have a lot in front of us, but some of the initial predictions were really high numbers that we haven't seen necessarily.
Thank goodness.
Yes.
And I think a lot of that is because people have stayed home, because people have done a good job of social distancing, because we've seen mask wearing to be pretty effective. But we also are starting to see lots of...
If you are hearing this message, then you're listening to the free version of J. Brown Yoga Talks. To hear the rest of our conversation, please subscribe to Podcast Premium at jbrownyoga.com/premium.